Bismillahirrahmanirrahim. I am Dr. Nadia Awais, Associate Professor Gynae, Independent Medical College. Today's online interaction is about endometriosis. The objectives of learning of today's interaction includes definition of endometriosis, its pathophysiology, etiology, sign and symptom of endometriosis, its relationship to infertility, and finally diagnosis and management of this disease. Now, starting with the definition, endometriosis is defined as presence of endometrium-like tissue outside the uterine cavity. The commonest sites include pelvic organs, peritoneum, uterosacral ligaments, pouch of Douglas, rectovaginal septum, and ovaries. In case of extraperitoneal deposits, it can involve lungs, cesarean section scars, or bowel can be involved. Now, the extent of disease, it involves small lesion as a spot to a large ovarian endometriotic cyst. The endometriomas will be formed. Extensive fibrosis and adhesion formation will result by presence of these endometriotic spots. It is present in 5 to 10% of the people, 20 to 30% who are investigating for infertility. They would have underlying endometriosis as a pathophysiology of their infertility cause. 40 to 60% of the patient who present with dysmenorrhea and chronic pelvic pain, they would have endometriosis. Pathophysiology, it involves the endometriotic tissue presence at certain areas. Wherever the endometriotic tissue is present, it will respond to the cyclical hormonal changes, which results in cyclical bleeding from these spots, and local inflammatory reaction occur, repeated bleeding, and finally healing will lead to fibrosis. This cyclical damage causes adhesion formation between associated organs and cause pain and infertility. Etiology include unknown many theories, and the commonest among them involve the menstrual regurgitation and implantation. Retrograde menstrual regurgitation, viable endometriotic gland and tissues, it will implant on peritoneal surfaces. There are certain conditions in which there is a genital tract abnormalities like presence of septum or the outflow tract obstruction. In case of imperforate hymen, the outflow of the menstrual blood would be obstructed and there can be regurgitation of the menstrual fluid into the fallopian tube and through fallopian tube into the pelvic cavity. Second commonest theory involves the coelomic epithelium, the differentiation of peritoneal cells, lining Mullerian ducts, transformation to endometrial cells, and wherever they are present, they would have a hormonal stimulus, inflammatory trigger, inflammatory reaction, formation of fibrosis, which will result pain and infertility. The third commonest cause is genetic and immunological factors. Increased susceptibility of women to develop endometriosis more in first degree relatives, and there would be a 7 to 10-fold increased risk in patients who have endometriosis in their parents or first degree relatives. Vascular and lymphatic spread, embolization to distant sites outside the peritoneal cavity. This is the pathophysiology or etiology of the problem in case of the distant site presence of endometriotic tissue, as I have discussed you about the lungs, the caesarean scar, or the involvement of the bowel. The commonest symptoms of endometriosis in relation to the site of the lesion involves, if the female reproductive tract is involved, it will cause dysmenorrhea, lower abdominal and pelvic pain, dyspareunia, rupture, torsion, endometriomas, low back pain, infertility. If the urinary tract is involved, there can be cyclical hematuria, dysuria, ureteric obstruction. In case of gastrointestinal tract involvement, there would be dyschezia, pain on defecation, cyclical rectal bleeding, obstruction can even occur. Surgical scar or umbilical endometriosis, there would be cyclical pain and bleeding can occur from these sites. In case of lung involvement, there would be cyclical hemoptysis. Pneumothorax can even occur in case of the most complicated cases. Now, by looking into the symptoms, you have seen the commonest symptom is in relation to the cyclical change. When there would be a cyclical presence of this symptom, it will reflect, it has a relation with the hormonal change, and there would be underlying pathology as endometriosis. Now, differential diagnosis which comes in your mind when the patient comes to you with the chronic pelvic pain include chronic pelvic inflammatory disease, adhesions, post-operative and pelvic inflammation. It can be due to torsion or hemorrhage into ovarian cyst. There can be some uterine, ovarian or cervical malignancy. It can be appendicitis, irritable bowel syndrome or cystitis. These are the different differential diagnosis, underlying pathology which should come in your mind when a patient comes to you with chronic pelvic pain. Now, endometriosis has a very strong relation to infertility. Infertility occurs in 30 to 40% of the patient having underlying endometriosis, they would have infertility. It has a multifactorial pathogenesis. Commonly, anatomical distortion occur with periadnexal adhesion, destruction of ovarian tissue that will result in infertility. Now, specifically how it causes infertility, if it is going to affect the ovarian function, there would be defective luteolysis with site maturation defects, anovulation, altered prolactin release. If they are going to affect the tubal function, there would be underlying adhesions, impaired femoral oocyte pickup, altered tuber motility, because it will affect the motility by cause a defect to the cilia. There would be coital dysfunction in form of deep dyspareunia due to severe pelvic pain. The patient would avoid coitus, and finally again it can end up with the infertility. Sperm function, there would be phagocytosis of spermatozoa, antibodies formation, early pregnancy loss can occur due to increased prostaglandin release and luteal phase defects. Now, diagnosis would be clinical history. In the history, there would be a strong history in relation to chronic pelvic pain and all the symptoms which we have discussed previously in previous slide, like there would be cyclical dysmenorrhea, premenstrual, postmenstrual severe pain, dyspareunia. There can be cyclical dysuria, hematuria, perrectal bleeding. If there would be some presence of pain in the umbilical or as a distance area in the some cesarean section scar, the cyclical relation will alert you. The age of the patient, if it would be in the reproductive age, because these are the cyclical hormones which are going to affect the patient endometriotic areas. Whenever there are cyclical changes, there would be release of the bleeding from these spots which cause fibrosis and adhesion formation. There would be pain and there would be increased rate of infertility in these patients. Now, on examination, per vaginal examination can be suspected by pelvic tenderness, fixed retroverted uterus and large ovaries, thickening or nodularity of uterosacral ligaments, adnexal masses. These all are the findings which you can assess in the patient having endometriosis. The investigations which are required to diagnose this disease involve non-invasive and the invasive in form of laparoscopy. Non-invasive tests include transvaginal ultrasound to diagnose the ovarian endometriomas. MRI has a more than 90% sensitivity and specificity for endometriomas. Even an endometriotic spot of more than 5 mm can be picked up by the MRI. Serum CA125 is elevated in deep endometriosis and endometriomas, but it is not a very specific test. The gold standard for diagnosis of for endometriosis is laparoscopy. Endometriotic lesion can be red, puckered, black, matchstick or white fibrous lesion. Now, this is a picture which beautifully shows the red lesion on the peritoneum. Another picture which is showing black matchstick lesions. These are the picture which we have taken from the patients during the laparoscopy evaluation of the patient. These are white fibrous lesions. They are formed even after the fibrosis of the previous endometriotic bleedings, and in the healing phase these all cause pain and infertility. Now the management, it depends upon fertility concerns, clinical symptoms of pain, extent of the disease. And while you are going to offer the treatment to the patient, you should consider the woman age, wishes for future conception, nature of symptom, severity of disease, previous treatment, choice of patient. Treatment options which are available are medical and surgical. For the medical options, non-steroidal anti-inflammatory drugs can be used, combined hormonal contraceptive pills, progestogens, diazole, gestrinone, GnRH analogs, agonist. These all are the hormonal management which you have to offer for at least 3 to 6 months in a continuity to stop the cyclical bleeding from the endometriotic deposits. So the cyclical bleeding will stop and there will be less formation of the adhesion. But keep one thing in mind, these medical management are only you can offer to the patient who are having pain as their underlying pathology, but they don't have a positive role in the patients having underlying infertility. Surgical treatment is the conservative treatment. Laparoscopic techniques can be offered: diathermy, laser vaporization, excision of endometriotic deposits. Endometrial cyst lining should be excised with cyst drainage. Recurrence following conservative surgery is 30%. The definite treatment of this disease is hysterectomy and bilateral salpingoophorectomy. Curative removal of the ovaries is essential and it should be offered in the patient in which there is severe symptom, progressive disease, completed childbearing, intractable dysmenorrhea and the pain, and post-surgical time period. Combined HRT should be given to the patient for at least 6 months. Now, considering all these factors in your mind, you can choose the right management for your patient. Thank you very much for today. This is all for the endometriosis. Go through your text by the different text available to you. The best for you at your level are the 10 teachers. You can see Dewhurst, you can see evidence-based, gynae and obstetrics. They will all help you for a better understanding of this problem called as endometriosis. Thank you very much.